Welcome everyone to the Nestle teleconference entitled Dietary Fiber and Pediatric Intestinal Dysfunction, Breaking Old Myths. My name is Carol Siegel. I'm the Manager of Professional Services for Nestle Nutrition and will be your moderator today. It is my pleasure to introduce our speaker, Dr. Jose Saavedra. Dr. Saavedra is a pediatric gastroenterologist. He's the Director of the Medical Scientific Unit for Nestle Nutrition and Associate Professor of Pediatrics in the Division of Gastroenterology and Nutrition at Johns Hopkins University School of Medicine. Dr. Saavedra is recognized internationally as the leading expert in the study of pre- and probiotics and their effect on the gastrointestinal tract. He has published extensively and lectures throughout the world on this topic. Without further ado, I'd like to turn the program over to Dr. Saavedra.
Thanks very much, Carol. It's truly a pleasure to be able to discuss, even though at a distance, topics that I hope are of interest to all those of you who help support the nutrition of our pediatric patients. We're going to try to discuss concepts related to enteral choices that are based on known facts, much of it which is common sense, much has been more recently supported from the point of view of the functional aspects of the diet that we give our pediatric patients. We're not going to discuss today modified diets or oral diets. We're not going to discuss specific diseases, which would be great to have time for, or discuss specific products. But my hope is that I can bring some concepts to you that will make you think a little bit more critically about how it is that we make decisions with regards to very specific components of enteral diets for those patients who require them. We have tended for the longest time to utilize nutrition as a way to deliver or maximize the delivery of nutrients to our patients. As we can see in the second slide, our goals of enteral nutrition are to maximize nutrient delivery, maximizing the quality of the nutrients that we deliver to our patients, or enhance nutrient absorption, including transport. This way, we can allow, of course, both the child or the individual to grow, to heal, and to help them repair tissues when we are talking about individuals who may have some kind of intestinal problem or a problem in any organ for that matter. And our goals until now have been to deliver these nutrients by minimizing any adverse effects of the delivery of the nutrients. And basically that's what we call tolerance. Our goal has been to maximize tolerance while delivering enteral nutrition to the host. Amongst those, of course, are the common examples of minimizing the chances of having upper GI intolerance, nausea, vomiting, regurgitation, and the complications that come from it, or decreasing lower GI tolerance, such as decreasing diarrhea or decreasing constipation, for example. However, it is critical to understand that the only way to deliver enteral nutrition is via the gut. And one of the things that unfortunately, we have not taken always into consideration when deciding enteral nutrition is that to be able to deliver enteral nutrition, we need to also nourish the route of enteral nutrition. The GI tract is that route. Next slide. To use the GI tract, obviously, the other goal of enteral nutrition should be then to support the gastrointestinal structure and the gastrointestinal function of that route to deliver enteral feeding. There's a number of ways that we can classify those things that we want to support the gut, or in the ways that nutritionally we want to support the gut. But it is critical that we support motility. Without things flowing, it is very hard to deliver nutrients. It is important to improve the barrier function of the gut to minimize the chances for toxins and translocation of bacteria into circulation. And it is also critical to support immune function of the gut, which in turn is critical for the immune function of the host, as we said before. We cannot forget that we can't feed the host if we do not feed the gut. The gut is that route of feeding. And unfortunately, we tend to forget that too often. When we consider the things that we need to do, next slide, in terms of factors for making decisions regarding enteral nutrition, we tend to think mostly of how to support the host from the point of view of growth and repair and immunity. And from that point of view, we look at or pay attention to macronutrients, what proteins, what fats, what carbohydrates, what other functional ingredients we might have there that help the host from the metabolic point of view. We tend to think of the micronutrient and mineral profile, for example. In other words, we seriously try to figure out those components in the diet that ultimately are going to help the host. However, as we said before, the other goal or the other factor to consider is what components of the diet are going to support GI structure and function, since that is the route to the host for all the nutrients that we want to deliver. We need to feed the GI tract. Next slide. One of the ways that we have tended to classify nutrition or the types of enteral nutrition that we give in terms of diets includes the type of protein. And in general, protein has been the macronutrient by which we have had different mechanisms or different ways of classifying the type of enteral nutrition that we use. Protein, of course, is important. Nitrogen is critical for delivering nutrition. And we have classified feeds by the type, generally, of protein that we give. Currently, the more common types of proteins in enteral feeding, of course, are bovine proteins, both casein, whey, or combinations of that, soy proteins, and in very, very small number of cases, other sources of proteins have been used in enteral feeding. Next slide. One of the most important components of protein from the point of view of support of GI tolerance has been the type of protein that we give. We won't go into any long discussion about the fact that for the most part, the proteins that we do deliver today are bovine proteins because they are, in general, a high-quality protein in terms of essential amino acids. But we must not forget also that bovine proteins, no different than vegetable proteins, behave very different physical-chemically. The differences between casein and whey are well known by everybody. Casein, by gastric digestion, particularly when there is normal amount of acidity in the stomach, will curdle, and this will lead to a significant amount of a casein curd formation, which ultimately decreases the chances for adequate gastric emptying. This doesn't happen in pediatric patients with human casein. This does not happen with other vegetable sources of protein, and it doesn't happen with soluble whey protein either. Next slide. As we said before, whey is a more soluble protein source. When you have any degree of significant GI dysmotility in a pediatric patient, you will have decreased emptying, increased amount of curd. In past, when there were large amounts of casein in the diet, this would lead to bezoars, for example, which we fortunately do not have because we have increased the amount of whey protein. Next slide. The other considerations with regards to protein have to do with the quality of the protein. And whether it comes to the amount of essential amino acids or the net protein utilization, which is the percent of protein that is retained by a host compared to the amount of nitrogen delivered, whey protein and casein proteins have typically been significantly higher than pretty much any other source of protein, probably except for egg albumin. Next slide. When we look at other protein quality measures, such as biologic value, which is the nitrogen retained versus the amount of nitrogen absorbed, or protein efficiency ratio, which is done in animals by which you quantify the weight of the animal for the amount of nitrogen that is delivered. Or when you look at protein digestibility and other measures that are done in the laboratory for quality protein measure, in general, whey protein, which is this bovine source, tends to be higher than pretty much any other source that we currently use. Now, there have been many reasons to use cow proteins as the main source, and as I said, from the protein quality point of view, this has led to the proliferation of most enteral formulations being defined by the type of protein. But it goes beyond the type of protein in terms of when we classify diets for people with gastrointestinal dysfunction of one or other type, whether it's a problem of absorption, or whether it's a problem of digestion, or whether it's a problem of transport. Next slide.